This is Merkel cell carcinoma, or primary cutaneous neuroendocrine carcinoma. And these tumors usually arise in sun-exposed areas in older individuals. And most importantly, they're really important to recognize because they often behave quite aggressively, and a significant number of patients will develop metastases and eventually die from disease. So they're a really bad tumor, and you definitely don't want to miss it. And from low power, kind of a blue tumor filling the dermis in an older sun-damaged person, really easy to think about basal cell carcinoma in some cases. So if you're just looking at low power and not thinking about it, it'd be easy to make that mistake. And that's a real pitfall because even though they're both carcinomas, basal cell carcinoma is very rarely causes mortality, and this tumor commonly does. And they're treated very differently. So it's really important to learn to recognize if you see a cellular, large, blue-looking tumor or a carcinoma. It looks like a kind of like a basal, but real dark and real cellular from low power. Always think about Merkel, and if you even think about it, go look closer and take some time to make sure that you're not missing that. So let's go a little closer and look. And like I said, Merkel cell carcinoma is actually a form of neuroendocrine carcinoma that arises in the skin, and it has similar features to those seen in other types of neuroendocrine carcinomas, particularly small cell carcinoma of the lung. So if you know what small cell carcinoma looks like in the lung, you basically know what Merkel cell looks like. It has a lot of similarities histologically. So the cells are arranged in kind of nests or aggregates. Sometimes they can be sheet-like and diffuse. Sometimes they can make large nests, other times small nests. One big difference that you'll notice when you look a little closer is they lack the basal palisading that's seen in basal cell carcinoma. So basal cells usually have palisaded nuclei around the outside, and it's pretty uncommon to see that in Merkel cell. I've seen it before, but it's not very common. So even though these are blue and kind of basaloid, they don't arrange themselves in the same way that basal cell carcinoma would. And if you look closer at the nuclei do, like I said, they do similar things to what you see in other types of neuroendocrine tumors. For one thing, they have this very kind of pale or fine, smudgy chromatin. People use salt and pepper chromatin, and I don't really love that term. I think it doesn't really look like salt and pepper to me, but people say that. I like the words stippled or fine or homogeneous or dusty kind of chromatin, but like all visual terms in pathology, you have to use the visual term that works for your mind. And the other thing is that look at what the nuclei do. You can see that the nuclei, they clump together and they mold to their neighbor. They're squished together and fit perfectly with the neighboring cells. They're not perfectly round. When they bump into a neighbor, instead of staying round, they kind of squish together and take on the shape of their neighbor. Like, look at that guy. He's got kind of a little triangular point on one end. Let's see if we can get a little bit higher power even for the video. Yeah, perfect. You can see those cells are just squished and molded perfectly together. They have this very fine, kind of dusty, smooth chromatin. They may have some small nucleoli, but usually Merkel cell does not have large, huge nucleoli. So that's kind of a clue. And here's again that kind of, it's a little bit hard to get to pick up on the video the exact quality of the chromatin, but it does have this kind of stippled, or I guess kind of salt and pepper is what people talk about, little tiny dots of chromatin in there. And occasionally you can see structures like this that are kind of almost rosette-like, where the cells are kind of making a little flower shapes. So sometimes you can see rosette type of figures in neuroendocrine carcinomas. Those are nice rosette-looking things there. I don't find that a real helpful diagnostic feature, but it is something you can see. And I've seen some that were even kind of spindled looking, so they don't always have this exact pattern. But in any case, this is a Merkel cell, and you probably have noticed already there are mitoses everywhere in this tumor. These tumors are some of the most mitotically active cancers of any of the cancers that I see in my practice. And the mitotic rate, when we diagnose Merkel cell, we provide some prognostic parameters, including the mitotic activity and the depth of the tumor and some things like that. And the mitotic rate for, say for a melanoma, the mitoses, you may have just 2 or 3 mitoses, or for a bad melanoma, maybe 5 or 10 mitoses in a millimeter squared, which on my microscope is about 3.5 high power fields. Every microscope's a little different. On Merkel cell, I've had, I think my highest that I've seen was 140 mitoses in 1 millimeter squared, or 3.5 high power fields. So amazingly more mitotically active than melanomas. And a lot of times you kind of have apoptotic cells and crushed cells, so it can make counting mitoses kind of hard. But let's see right here, you can see there's a mitosis there, there's one there, here. So they're all over the place in here, lots of mitoses. So to confirm the diagnosis, what I like to do, if it looks like this looks classic, this looks very, just on H&E, I'm basically almost 100% certain that this will end up being a Merkel cell carcinoma, but it's such a bad diagnosis, we want to be totally sure. So one thing that I like to do is I use an immunostain, cytokeratin 20, and cytokeratin 20 is positive in almost all Merkel cells, and it typically, not always, it doesn't have to do this, but it typically has this amazingly beautiful perinuclear dot-like pattern, or people call this the Golgi pattern sometimes. But these dots, these really darkly staining, perfectly punctate round little dots that are in each cell right next to the nucleus. Look at that. Amazing. So you can see the nuclei here, and you can see these dark dots of cytokeratin 20 staining, which if I have a histology that's classic like this and CK20 positive, I feel totally comfortable making a diagnosis of Merkel cell in that setting. Are there other things that could potentially mimic that? I suppose so, but very, very uncommon. Now, the main thing that you probably think of and that people talk about a lot is, what about metastatic small cell carcinoma from the lung or from other places? Well, I'll tell you that I see Merkel cell carcinoma pretty commonly in my practice, and I've still to this day only seen one, or maybe I think maybe two cases of metastatic small cell carcinoma from the lung in the skin. And in at least in one of the cases, the patient already had known disseminated disease, and the finding was already known. So it wasn't it was metastatic, but it was because the patient had widespread mets, and the recognizing that it was a metastasis would not have made any difference in patient care. But I think that we often worry, well, what if we call something Merkel and it's actually metastatic small cell? So that's very uncommon. But to me, the easiest way to solve that is if you do a CK20. CK20 is a positive almost always in Merkel cell, and very, very uncommon to be positive in metastatic small cell carcinoma from the lung. So you're and you're already in a site where the odds of this being Merkel cell are much, much higher. So I feel like that is pretty confirmatory most of the time. Now, if the CK20 doesn't work, or is kind of wishy-washy, then I can do other stains. Neurofilament stain works very nicely and often gives you a similar dot-like pattern. And just of note, other types of cytokeratins like pan-cytokeratin will often stain with this dot-like pattern as well. So the dot-like pattern is not totally specific. Other tumors can do that. And it's not required either. You can have diffuse cytoplasmic staining that's not dot-like in Merkel cell carcinoma. So don't think that you have to have dot-like staining, but this is the typical classic finding that you see. So neurofilament will work, and then you can use other things like synaptophysin and chromogranin, which are neuroendocrine markers, and those will stain here too. But I don't usually do those as first line because if it looks so good for Merkel cell, then I just do a CK20 and that solves the problem usually. And TTF1 is a marker that's going to be positive almost always in small cell carcinoma of the lung, and is very uncommon. I'm sorry, it's also potentially positive in small cell carcinomas of other sites, including Merkel cell. So TTF1 positivity could potentially be seen even in a Merkel cell. If TTF1's negative, that would be further argument against metastatic small cell lung cancer. If it were positive, I would probably put a comment in the report that, even though that can be seen in Merkel cell, the patient probably needs a imaging of their lung to make sure that there's not a small cell carcinoma there. So, but again, I don't usually resort to that as a first line. I do that if my CK20 is negative, or if it's not very good, then I might add on a TTF1, a cytokeratin 7, which would stain metastatic small cell carcinoma from the lung. And there are lots of different approaches to this. Immunohistochemistry is kind of somewhat of a science mixed with art, because everyone has a different approach that they take with cases. But this is my approach, CK20, and it's staining a Merkel cell carcinoma. Right, so here we are in the scalp. This is an excision specimen, and you can see that we're in the scalp because there are multiple large anagen hair follicles, and their roots are present down in the subcutaneous fat. So that usually means you're in the scalp or the sideburn area, somewhere close to the scalp. And this kind of funny black line here, this is an air bubble underneath the slide, so that's just artifactual. It's a little bubble in the mounting media. But the reason I wanted to show this is a biopsy had been done here, and there was an atypical melanocytic lesion here that was re-excised. But why I'm showing this is a nicely healed or healing biopsy site that's converting from granulation tissue into scar. And you can tell even from low power that this is going to be scar, because you can see that the normal dermal collagen is this nice bright pink color, and here there's a whole zone where that collagen's gone and it's replaced with a much more pale colored collagen and some spindle cells. We'll go down for a closer look. The other clue to scar that you can see is the epidermis. Normally, remember, epidermis looks like this. It has reedy ridges, those long finger-like structures that stretch down into the dermis. And those reedy ridges are completely gone here. So whenever we see loss of the reedy ridges, we call that epidermal atrophy. So atrophy usually means a thin epidermis, but particularly it means not only thin, but a thin epidermis with loss of the reedy. And you classically will see loss of the reedy when you have scar formation, because this whole area here was shaved off by a razor blade. A shave biopsy was done by the dermatologist, and then it filled back in with granulation tissue that turned into scar, and then the epidermis from the sides and also from the hair follicles sent stem cells that regrew and formed a new epidermis over top of the scar. So that's how wound healing happens in a nutshell. That's the basics of wound healing. And so what you get is a scar in the dermis, and then the epidermis over top has this completely flat, effaced pattern where it's lost the reedy. So learning to recognize that is useful, because sometimes as the scar gets older, it matures and it looks more pink like the rest of the dermis, and it can be easy to overlook scars if you're not thinking about it, but looking for that loss of the reedy is helpful. And eventually, over a long time, those reedy do start to regrow, but it does take some time. So let's take a closer look at scar. Scar sounds like a basic kind of thing, but that's what this is about, seeing some basic common Dermpath things and recognizing scar is important. So there's a couple things about scar. For one, scar is made from fibroblasts and myofibroblasts, that as the wound is healing, the myofibroblasts come in, form granulation tissue, which is myofibroblasts and some inflammation and vessels. And then over time, the myofibroblasts, either they convert to fibroblasts or new fibroblasts grow. I don't understand fully how that happens, honestly. I think of myofibroblasts and fibroblasts as closely related to each other and able to transition back and forth. There probably are cellular biologists out there who are appalled at my lack of understanding of those in-depth details, but that's the truth. So in any case, whatever you get a mixture of fibroblasts and myofibroblasts, and they begin to lay down collagen. So you can see the pink fibers being laid down here between these spindle cells. That's collagen. And it's more pale because there's other things in here too. There are other things like elastin fibers and reticulin fibers, which is collagen type 3, and you can't really tell those here, but you can do stains to see those things. And there's also going to be background mucopolysaccharides, ground substance, like hyaluronic acid, and all that blended together gives you this kind of more pale look. So see, compare, this is normal dermis, dense, big collagen type 1 bundles. And then here, this area up here has a mixture of collagen 1, collagen 3, a little bit of elastic fibers, not very much, but a little bit. And then also you're going to see vessels. But the most important thing for recognizing the scar is that the fibroblasts, these bland little spindle cells, they're all parallel. They're running together, or they're kind of swimming together like a school of fish, if you like that analogy. That's what a lot of people who trained me like to say, the school of fish, that these fibroblasts are all running in the same direction. And then punctuating in the middle of the scar, you see vessels, and the vessels are more vertically oriented. They're going straight up. So I kind of think that they're like the pillars that hold a pier up. I grew up near the beach in Florida, and so we had lots of piers, and so those pillars kind of hold the pier up out into the water, and then the fish are swimming like a school underneath it. Maybe that analogy is not very good, but that works for me. So you have to figure out an analogy that works for you. And again, the reedy ridges are totally lost up here. You see a little bit of hemorrhage, and just like in granulation tissue, young scars will have some hemorrhage as well. And over time, this will become more and more pink and less cellular, and then an old scar gets very pink and has very few fibroblasts, or relatively few fibroblasts compared to this kind of young scar. Now, you can't really look at the scar and say exactly how old it is, but I can tell you that this is a relatively more recent scar, and I actually know because of the history that that's the case. So that's what scar looks like. You can see that the dermis is replaced with this kind of new formation of collagen, fibroblasts and some myofibroblasts, and those vertical vessels. So that's what scar is. let's get oriented here. This is so large I can't even put the whole lesion here. You can see it doesn't even fit all under one objective field, even at the lowest power I have. Now here's some scar. The epidermis doesn't show that effacement of rete, and that's probably because this scar has been here for quite some time. It's kind of an older scar. And you see that there are those fibroblasts and collagen out here. They're not quite as organized into the little school of fish as we had before, but there are prominent blood vessels and there are fibroblasts in here and collagen. And there's a lot of inflammation. This scar is a lot more inflamed than the one I just showed you. These small dark dots, those are all lymphocytes and some histiocytes and plasma cells maybe mixed in. But this scar is a special kind of scar because it has these huge, thick, pink bundles of collagen. And so these bundles look kind of like the dermal collagen bundles that I showed you just a second ago, the collagen type 1. And that's what these are made of, is collagen type 1, but these are much bigger and more dense and smudgy kind of pink appearance. And they're embedded here in the middle of this scar tissue. So you can see that there's a kind of a pale background and then these bright pink, smudgy bundles of collagen in here. So when you see the presence of those bundles, we call those keloidal collagen bundles, and that's because this is a keloid, which is a type of scar that is overgrown. And I also consider hypertrophic scars as closely related to keloid. The difference is, in my mind, mainly clinical, that a hypertrophic scar is a thickened area of scar that'll look like this microscopically most of the time, but it stays within the confines of where the injury happened. Like if you had a surgery, the scar, the wound may kind of stretch a little bit and have a thickened area, but it's at the same site. And then a keloid, on the other hand, usually grows, mounds up and grows and bulges over and outside of the confines of where the original injury happened. And so keloids are very common and they're very problematic. Even though they're benign, they're just really excess scar formation because of all this extra collagen production. For people who get these, this is really problematic. And so people of African ancestry have a tendency to get keloids, although other people can as well. And this is very problematic. And if you go and cut the keloid out, it has a tendency to grow back and make another keloid. So it's a real problem, and it can be very disfiguring and cause a lot of morbidity. And so this patient is dark-skinned, and you can tell because of the increased amount of pigment. Well, it doesn't show it very well on the video here. Let's see if I can show you. And sometimes that's helpful. You know, the forms don't always tell you whether a patient has dark skin or light skin. And in Dermpath, that's actually really important to know the skin color or skin tone, because people with dark or light skin get different kinds of diseases. There's some diseases are the same, but there are other diseases that are very, very different. Dark skin patients don't get as many types of sun damage related skin cancers. They're much less likely to have melanoma in typical sites. There's a lot of differences there. And so we have to recognize those and talk about those to be able to practice good medicine. But you can see here the melanin pigment. And there's actually more, it just is kind of washed out on the video. And so there's increased melanin pigment throughout the whole basal layer of the epidermis. Normal number of melanocytes, just increased pigment, and that's what makes skin color darker or lighter, is how much pigment is there. And again, here's the collagen bundles. So this is a keloid. This big space in the middle is just artifact. Sometimes these are so dense that when we cut them in the laboratory, the microtome blade, the tissue doesn't want to cut correctly. So the reason this keloid is here, this is on the earlobe. And this person had their ear pierced before. And so we see a lot of different types of cysts, but here's a little fragment of a cyst wall. And this cyst is probably a true epidermal inclusion cyst. A cyst that happened because when someone got their ear pierced, a little piece of epidermis was punched down into the dermis, and then the dermis healed and scarred around it, but that epidermis that got pushed down into the dermis didn't die. It tried to regrow and it formed a little cyst. So we call lots of cysts like this epidermal inclusion cysts, or a lot of people do, but actually the only ones that are truly epidermal inclusion cysts are ones that are like this, that are inclusions of epidermis down into the dermis because of penetrating injury. So you can see it in the context of getting an ear piercing. You can also see it like on the feet or the lower extremity from someone who stepped on a stick or you know, had a traumatic injury with a sharp object, and sometimes a little bit of the epidermis will get pushed down into the scar tissue and will then regrow and form this little cystic structure here. And so most other cysts that we see that look like this but are not in the context of a penetrating injury or a scar, those are usually actually derived from hair follicles. So we call them, in Dermpath, a lot of people call them follicular cysts, or a follicular cyst, the infundibular type. And so that's actually what I call those. So a lot of people will call them epidermal inclusion cysts or epidermoid cysts, and I call them follicular cysts. But in this case, this actually is probably a real epidermal inclusion cyst. So that's probably more nitpicky than you cared about. But in any case, the point of both epidermal inclusion cysts and also follicular cysts of the infundibular type, they look like normal epidermis, right? right? And if you go look at the infundibulum of a hair follicle, the part where it empties out into the epidermis, the lining of the infundibulum looks just like the lining of the epidermis. It's stratified squamous. So it's got the kind of more cuboidal or rounded looking cells right on the bottom layer. And as it goes up, the cells get more pink, abundant cytoplasm. You'll see spinous little spines, desmosome spines here between keratinocytes. It's a little hard to sometimes appreciate on the video, but they're there. Let's see if we can get them to stand out. Yeah, there. So when you flip the condenser, you can see those little spines between the layers. So just like normal keratinocytes in the epidermis. And then as you go up towards the center of the cyst, you begin to see a granular layer made of these purple keratohyalin granules. And then the keratin finally in the what's analogous to the corneal layer, the center of the cyst, makes this loose, flaky keratin that kind of flakes loose and fills up the cystic space. So normally if you see something that looks like epidermis, say you have a fragmented specimen, but you see this much keratin with it, you're almost always going to be dealing with a cyst probably, because you can't, it's really hard to build up that much flaky, loose keratin on the surface of your skin. So if I just showed you this piece and you didn't have any context and you couldn't see if this was up or down or in the dermis or on the surface of the skin, you could look at that and pretty reasonably say we're dealing with either a follicular infundibular cyst or an epidermal inclusion cyst, whatever name you like, but we're not dealing with skin surface, because even though the epidermis or the stratified squamous epithelium looks the same, the difference is that you have all this loose flaky keratin there, loose flaky keratin, which is not going to be able to build up to that extent on the skin surface. So that's a nice little trick if someone ever wants to show you a real close up there. But here, just looking at low power, you can easily see that's the surface. Here's the keloid, and here's what caused the keloid is that little, or is related to the keloid, this little cyst down here that's also ruptured and inflamed. And that's the problem, is these keloidal scars. The cyst is there, the cyst ruptures, it makes inflammation, it makes more scar, the scar keloids, and it compounds the problem, and it's a vicious cycle, unfortunately. So that's an example of keloidal type scar, and also of epidermal inclusion cyst, which is similar to what follicular infundibular cysts look like. Let me show you, that's not the only type of cyst. There are actually many different types of cysts that you can get in the skin. Most of them are related to hair follicles, or the most common ones we see are, but there also can be from sweat glands or sweat ducts. You can see cysts, and then there are some cysts of more esoteric, unusual embryologic origin that we're not going to get into right now. But there's a lot of different types of cysts. Now here's a totally different cyst. You can see there's a space here in the middle, and this is again as low of power as I can get, but you can see there's this large, very perfectly circumcised ball basically, and that's what these look like. These are usually going to occur on the scalp, and they look like a nodule, and when the dermatologist cuts it out, these things will pop out just like a little marble was underneath the skin. They're firm and round, and they usually can kind of shell out or pop out intact like this. So this is a type of cyst called a pilar cyst, or if you want a different name, a trichilemmal cyst, or if you want another different name, you can call it follicular cyst of the isthmus catagen type. See, this is why Dermpath is kind of challenging, because for everything we have 3 names or 4 or 5 names, and they're usually long, and they're oftentimes in Latin. So, I'm a dermatopathologist, so I'm allowed to make fun of our specialty too a little bit. But in any case, pilar cysts are also derived from hair follicles. That's why the other name for them is follicular cyst of the isthmus catagen type. They derive from they recapitulate at least the portion of the hair follicle near the isthmus, which is the part where the sebaceous gland drains into the follicle. And if you go look at the lining of the follicle in that area versus the surface, which is the infundibulum, you'll see that the lining does look different. So see, normal histology is actually quite important. But if you're not a nerd like me and don't care about all that stuff, that's fine. You just want to learn how to diagnose these things, that's okay too. So here's what the lining of a pilar cyst looks like. It looks a little different than what I just showed you for the follicular infundibular cyst or epidermal inclusion cyst. The lining itself looks relatively similar. It's stratified squamous. The cells in the middle portion here are a little bit more rounded or cuboidal in appearance, and a little bit less of the kind of stratified squame looking. It is the same type of epithelium, but it looks a little different. But the most important differences are at the center of the cyst, or I guess what's analogous to the top of the epidermis. I guess I should go make it look straight up and see. Well, I guess we were good where we were. I should have left it alone. When you get up here, normally you would have a granular layer. There's no granular layer, or very little. These can have a little bit of granules, but not much. So the granular layer is relatively absent here. And instead of loose, flaky keratin that you're getting in the center of the cyst, you have dense, smooth, homogenized keratin that's all packed densely together. And it's so packed together that it actually fills up the entire center of the cyst usually. Sometimes you'll have a little space in the middle that's left. But really, the cyst is almost completely full of this dense, wet kind of keratin. So that dense, packed, tight keratin and that absence of the granular layer, when you see that in a cyst, and usually the cyst looks like this from low power, that's a pilar cyst, okay? And pilar cysts often do this too. Look at that. This bright, or this dark kind of purple stuff. This is calcification. And so you can see calcifications in lots of different settings in the body, but you often see it in association with pilar cysts. In the middle, in the keratinized portion, it begins to pick up calcium salts, and so that is, that's calcification. And you can kind of see it's a little refractile, and it's always this dark purple color. All right, so that's a pilar cyst. And sometimes the lining of the pilar cyst will begin to grow and proliferate into the tumor and kind of almost looks like squamous cell carcinoma, and that's called a proliferating pilar tumor or a proliferating trichilemmal tumor. And those have some overlapping features of this, but a lot more cellularity, and I don't have one of those handy right now to show, so I'll have to show that at another time. All right, let's do one other type of cyst here. Well, first of all, we have to figure out where we are. So normally that's written on the requisition sheet that the specimen comes in with, but sometimes it's not, or occasionally specimens get, mislabeled or swapped. No matter how good your lab is, that always can happen, and so we have to be vigilant and always think about that. So when I see these glands, these are very different than the glands we see in most parts of the skin. These glands have very big, plump epithelioid cells lining them that have really dense, abundant eosinophilic cytoplasm. They have these little snouts or blebs that protrude into the lumen, and then they have these nice round, very uniform nuclei that have prominent central nucleoli. They look like little eyeballs or little minions. It's like the little one-eyed minion staring back at you, lined up in a row here with all his buddies. And so that that is an apocrine gland. And apocrine glands are usually only seen in the intertriginous area, in the axilla, in the groin, and you can also see them near the eyelids, sometimes by the nipple, and occasionally in other spots, but most of the time apocrine glands are only in those areas. So here, when I have numerous apocrine glands, that means we're probably in the groin or the axilla, and in fact this is in the axilla in this particular case. And this was taken out because it was a cyst. And this cyst, again, has a squamous stratified lining just like the other ones. But again, see the main difference between all these cysts is not the stuff out here, it's what's happening right here at the center of the cyst. This one does have some granular layer, but what's different about this cyst is look at that inner lining. It's loose and flaky in the middle, but it's got this really dense pink kind of outline, like it's wearing lipstick or something. It's like this bright pink, very, very noticeable outline, and the outline has this tendency to get kind of wavy or like jagged. It looks like shark's teeth or something, kind of jagged, going up and down with this dense pink lining. We call that a cuticle, that lining. And see there that it's this jagged kind of sawtooth looking pink cuticle. So when you see a cyst that's lined by that, that is called a steatocystoma. And steatocystomas are actually derived from a portion of the hair follicle. The portion that they're coming from is actually called the sebaceous duct, where the sebaceous gland drains into the hair follicle. And if you go look at a normal follicle, you'll find that the lining of the sebaceous duct, you don't see the sebaceous duct very often, but when you get the right cut, you can see it. And sure enough, it's lined with stuff that looks just like this. And look, these actually truly are sebaceous. A sebaceous cyst. A lot of times surgeons that are kind of old school will use the term sebaceous cyst to refer to all cysts, and actually very few cysts are truly sebaceous in origin, but this one really is related to the sebaceous gland. And here you can see these bubbly sebaceous glands that often connect to and enter into the wall of steatocystomas. You don't have to have that, but if you see it, that's a nice finding. Let's see, I think I've got another slide here that shows a little better. Oh yeah, this is beautiful example of that kind of wavy or jagged sawtooth look of that dense pink cuticle. Very classic for steatocystoma. Sometimes you'll have small little hairs that are in the middle of the cystic space. That's normal. And maybe it's a different slide. One of these showed it nicely. Perfect. And when you see it, this is really nice. A sebaceous gland draining directly into the cystic lumen. So steatocystoma, yet another one of the many types of benign cysts that you can see in the skin. So here is yet another type of cyst. This was a shave biopsy of a kind of a bluish or translucent kind of looking papule on the eyelid. And you can see there's this large space in the dermis. And you know, let's take a second. When you see an empty space in the middle of skin, Dr. Rowe, one of my great mentors in residency, taught me that if you see an empty space, a white space in the middle of tissue, it's one of three things. Either it is a glandular or cystic space, meaning it's lined by epithelial cells, or it's a vascular space, or lymphatic or vascular space, meaning it's lined by endothelial cells, or it's an artifactual space, meaning it's space that's happened because something was there in the tissue that's been washed away or fallen out during processing, or because the tissue is torn or fragmented or separated during processing. So just very briefly, this is an empty space, and it has a lining made of epithelial cells. We'll come back to that in a second. This up here, this is an empty space, but this is lined by a thin layer of vascular endothelial cells, so that's a vascular space. And these spaces right here, they don't have any lining. These are just kind of cracks that have opened up in the tissue during processing. So anytime you see a white space, pretty much always you're going to be able to put it into one of those three categories. Either it's artifactual, it's vascular, or it's glandular slash cystic, meaning it's lined by epithelium. So let's come back to this glandular slash cystic space here. This is a space that is open, doesn't really have much in it. And if it had any contents in it, it's probably washed out during processing. And so let's come and look at the lining. So that's how we classify cysts usually, is by their contents and then also by what kind of lining they have. And the lining of this cyst is made of these kind of little round cells that we call these cuboidal. When epithelial cells are kind of round, you can imagine that the edges of each cell would kind of give you a square sort of shape. So we'd say they're cuboidal. And they're kind of a double layer of cuboidal cells. See, there's kind of like one layer along the bottom and then one layer along the top, an inner layer. Well, there's two main types of tissue that give you a double layer of kind of cuboidal to columnar. Cuboidal and columnar cells are kind of closely related. Sweat ducts do that, and then also some parts of the salivary duct system do the same thing. And sweat glands and salivary glands actually have a lot in common, and we see a lot of similarities in the tumors that come from sweat gland origin in the skin, as well as salivary gland origin in the head and neck region. So I think there's a lot of similarity there. So in any case, this is a double layer of cuboidal cells. And you can also see that some of them have these little kind of tufts or blebs sticking into the surface there. So when we see that, we often think of apocrine cells. So this is actually a sweat duct cyst, a cyst derived from sweat ducts, and this is called a hidrocystoma. And hidrocystomas can either be ecrine or apocrine. I don't make a big deal about telling them apart. It doesn't really matter. If I happen to see little apocrine snouts, you can say apocrine hidrocystoma. But for practical purposes, it doesn't matter because they're both benign. And they usually occur as multiple little bumps that have a kind of a bluish or a translucent kind of look to them. And they're usually on the upper cheeks or the eyelid area. So they can be multiple. So we see these as biopsies a lot. And the other thing is that sometimes, because the eyelid, you don't necessarily want to do a big biopsy, sometimes people will get a little kind of thin shave and just barely nick the top of it. So if you're looking at a bump from the eyelid and it looks like normal skin and you can't see much there, try to always remember to look down at the base of your shave biopsy and see if you can find a little tiny touch of hidrocystoma hiding out down there. And see, they tend to have kind of a dense layer of collagen around them, so sometimes all you'll see is that layer of collagen, and that can make it a little bit tricky if you don't know what to look for. So here, let me show you. I think there's another section from this, and you can see see what I'm talking about? Here you go. You can see the cyst right here, no problem. And that kind of snout-like apocrine layer is a lot easier to see here. So that's just another part of the apocrine hidrocystoma. But look here. See that dense band of kind of basement membrane material? And there's just a tiny bit of epithelium, but most of it's kind of ripped off or torn away during processing. But if you see that kind of band of dense pink stuff, always stop and think, oh, maybe there's a hidrocystoma, or other types of sweat gland tumors particularly will tend to have a lot of this dense pink basement membrane material. So if I ever see a lot of that in the skin, I always start thinking about a skin adnexal or a sweat gland tumor. So hidrocystoma, benign from the eyelid. Now let's look at this. This is a shave biopsy of a papule, a little bump, on acral skin. And you can tell it's acral skin because it's got a thick epidermis and a really thick layer of orthokeratin for the corneal layer. And it's a little bump coming from the skin surface. You can see that this nice little swirly thing. Those are called acrosyringia, or acrosyringium is the singular. And that's where the eccrine sweat ducts drain out to the skin surface. So I think those are really pretty. And you can see the little tube going up there into the surface. So that's an acrosyringium. And then here in the dermis, we have a proliferation of spindle cells. That's what's causing this little bump. So let's see if we can figure out what those are. Here, they're bland little cells. They've got kind of a pale pink collagen background. See the collagen, the normal dermal collagen is that bright pink stuff there. The pink here is much more pale, like a light pink color. And the cells are bland and spindled. Some of them are kind of rounded on one end and pointed on the other end. Kind of like a little sesame seed, like those little seeds you get on your buns if you go to get a sandwich, a burger or something like that. They have those little seeds. Those are sesame seeds. And some of these have like that kind of like a point on one end and a little rounded on the other end. So some people have compared them to sesame seeds. Some of them are spindled and look kind of bent or curved or crooked. Sometimes people say that these are wavy, but I don't really, that terminology doesn't usually resonate well with me for these. But these are Schwann cells. And the way the Schwann cells are arranged, all sorts of nerve sheath tumors can have Schwann cells, neurofibromas, Schwannomas, things like that. But here you can see that there actually are, these cells are actually arranging themselves into little tiny nerve bundles. And see, look, here's a nerve bundle, here's a nerve bundle, here's another one. There's a bunch of nerve bundles all together, actually. So when you have a bunch of nerve bundles in one place, we often refer to that as a neuroma, and there are several different types of neuromas. So you might think, well, this could be a neuroma, like a traumatic neuroma. If you get a surgery or you injure yourself, sometimes the nerves will try to regrow and they'll tangle together and make a little collection like this, and we say that they're a neuroma. See, and here, let's look at the other piece. You can see much more clearly, there's kind of, the collagen here is really dense, kind of almost scar-like, and then you've just got a big tangled bundle of all these nerves, way too many nerves for normal skin. You normally have just occasional nerves that are scattered around and not like these big bundles of multiple nerves kind of tangled together. And oh, look, that's cute. See that little guy there? That's called Meissner's corpuscle, and it's like a little ovoid structure made of a bunch of little cells that are kind of stacked together. And let's see if I can get it to show up. If you kind of refract if you flip your condenser, sometimes you can see there's kind of like little thin layers of pink in the middle of this thing, and it gives this kind of striped appearance that reminds me of like a little Easter egg or something. These are fine touch receptors, and you pretty much only see them on the volar, the palmar or plantar surface of acral skin because they're for fine touch, and that's why they're right up underneath the epidermis so that they can feel the finest little touches there, and that's why they give you fine touch, and that's why your fingers are fine touch receptors. So that's nice. You see, and look, there's quite a few of them. There's little Meissner's corpuscle. Oops, sorry, it's a little blurry. Meissner corpuscle. There's another one there. And those are just normal histologic structures, but they're actually important because when you see them, it gives you an idea that you're probably on palm or sole, even if no one's told you that. There's another one. And then also we see things that look kind of like Meissner's corpuscles in some tumors, particularly diffuse neurofibromas. We'll give you these, what we call Wagner-Meissner bodies, and you can see similar structures in neurotized nevi, and we'll have to talk about those things some other time. But so it's good to recognize the normal histology because sometimes tumors try to recapitulate what normal histologic structures are. So recognizing all that stuff's important. But anyway, so we have this tangle of nerves, and we're on acral skin, or we're on the distal fifth digit. So at the kind of lateral edge of the pinky. And interestingly, this is a young child, a 2-year-old. And look what they had on, that was from the right hand. Now let's look on the left hand in the same exact place. We have something very similar. There was a bump, like a mirror image on the other side, on both the right and left hand, on the lateral edge of the fifth digit, there was this little bump, and so the dermatologist knew exactly what this was, and the family wanted it to be removed, understandably. So most of you who are savvy to this already have this figured out. This is an accessory digit. This was an extra little finger that was trying to grow that never quite made it. So a supernumerary digit or an accessory digit, this was like a little sixth finger. And it was usually what they do is they just make a little bump or a nub, and it has like all of the nerve bundles that would normally innervate the finger kind of get tangled up together. You'll often see Meissner's corpuscles underneath it because it's trying to make a finger, so a normal finger would need Meissner corpuscles and would need nerves. And I've even seen some that are so well developed that they actually have bone and cartilage in the middle. That's pretty uncommon. The vast majority of them look like this. They look like a little neuroma, basically. So if you see a bump on acral skin that's kind of fibrous, always look in the dermis, and if you find these nerve bundles, and if you're in the right location, which would be the lateral 5th digit, then you're probably dealing with an accessory digit. And they're almost always bilateral. I don't think I've ever seen a case that was not bilateral. I'm sure it's occurred, but I've never seen it. And the dermatologist almost always knows what this is, and they're just removing it for cosmetic reasons for the family. And then see down there, you can see the large nerve bundles kind of feeding into this thing. So really nice example of accessory digit. These are always kind of fun to see. And benign. All right. Now let's change gears a little bit. This is a biopsy from the ankle, and this patient had kind of a plaque that was reddish purple and like a dark purple kind of color and irritated. And the dermatologist was worried that it might be a vascular tumor like Kaposi sarcoma or something like that. So let's try to work through this. First of all, we have the epidermis is not normal, right? The epidermis starts to look kind of like acral skin, but it's also got a really thick granular layer, so this has been scratched and irritated a lot. And there's also a lot of spongiosis. And remember, we can see spongiosis because it's white space in between the keratinocytes. That's fluid that's leaked up into the epidermis, and we can see usually in spongiosis is a good time to see the desmosomal spines of the keratinocytes. They get stretched out, and they're like just holding on to their neighbor for dear life, like Rose and Jack in the Titanic. So one of the students once said that the desmosomal spines are saying, "I'll never let go." So maybe it's a bad joke, but I thought it was really funny, and that's how you know if you're a dermatopathologist. Beautiful, right? Beautiful spine. So those desmosomes are really strong. They can hold on to their neighbors really tightly. So anyway, there's spongiosis. There's that dense, thick granular layer means that someone's been scratching at this, so it's kind of what we call lichenified. But the big reason that the dermatologist is seeing all this purple change and removing this is look at all these blood vessels in the dermis. Sorry, I'm trying to get in a focus here. I got distracted by those desmosomes. So here we go. The dermis is definitely abnormal. Instead of just having collagen, it's loaded with blood vessels. And these blood vessels are well formed. Each one is a nice little round or oval lumen here. And they've got a nice wall of endothelial cells and little pericytes around them. But there are so many. The wall of the vessels is thick. See, look at how thickened. The capillary is supposed to be really thin walled, but this little thing is about capillary or venule size. But it's very, very thickened, and it's got a lot of collagen around the wall. And they're like kind of tangled together here. But if you look from a little bit lower power, you can see that these vessels are making kind of a lobule. See, they're a bunch of little vessels, but they're all arranged into kind of one area. And then you can go over here and the same thing. See, this is like kind of a lobule of kind of a coiled up tangle of well-formed vessels. Same thing, sometimes you got to go out a ways to see it. Same thing here. Here's kind of a lobule of vessels. Here's a lobule of vessels. So that's useful that benign vascular things often grow with a lobular configuration. Now there's exceptions to those rules, of course, but a lot of times benign vessels, either reactive or in neoplasms, will grow in these kind of lobular arrangements. So that's a helpful thing. All right, and I don't see any infiltrating kind of spindled endothelial cells or slit-like vascular spaces like I'd expect in Kaposi sarcoma, and we'll have to go over Kaposi some other time. But that's definitely an important consideration because Kaposi does occur in the setting of HIV, but also there's the kind of classic form that occurs usually on the distal extremities of older individuals. It's been typically described in Mediterranean, people of Mediterranean origin or Ashkenazi Jews, but it's actually, I see it in old people from any type of ethnicity, and it's probably because as people get older, sometimes their immune system doesn't work as well, and if they've been exposed to HHV8, that reactivates the virus, and then it lets them get Kaposi sarcoma, and it has a tendency for the lower legs or the feet. So it's always good if you see a violaceous or erythematous lesion on the lower extremities, always think about Kaposi. But this is not Kaposi, this is something else. And so these vessels, again, they're very nicely formed, they're arranged in lobules, and in addition to, it's not just vessels that we have here, there's a lot of blood, right? And so the blood is leaking out of the vessels, And we have evidence of that, not just because we're seeing red blood cells, but we're also seeing this golden refractile pigment. This is hemosiderin. So we're seeing a bleeding over long term. These vessels are thick and proliferating. There's a lot of collagen and fibrosis in the background. There are all these little red blood cells leaking out of the vessels, and there's evidence of that because there's hemosiderin. So this has been going on for quite some time. And so what this is this is a very, very severe form of stasis dermatitis. So everyone over time, as we age, gravity works against us and pushes back down on the blood that's trying to kind of come up from our legs back towards our heart. And the vessels get really tired of this over time, and they begin to kind of proliferate and thicken from that extra back pressure. And we call that stasis change. So everyone gets some degree of tangled, kind of coiled capillaries in their lower extremities. And the older you get, the more of it you get. And some people have really bad stasis, and this is an example of that. And when you get bad stasis that's so bad that it starts to make kind of a plaque or a violaceous area and begins to make all this kind of fibrosis and scarring and hemosiderin around it, we call this acroangiodermatitis as a fancy name for it. So usually how I sign it out in my report is severe vascular stasis, and then in parentheses acroangiodermatitis. And this is kind of another term that people have used for this is kind of pseudo-Kaposi sarcoma. It looks a lot clinically like Kaposi, and microscopically it can really mimic Kaposi sarcoma. If you have any doubt, you can do an HHV8 immunostain. Another thing you can do is you can do a vascular marker like ERG or CD31, and you can couple that with a smooth muscle actin, and what that will show you is the vascular marker shows you the endothelial cells, and it will give you this, even though this is very busy and cellular, it will show you, oh, the vessels are actually all very nicely formed, and they're all surrounded by a nice little layer of pericytes, which will be actin positive, and then the background spindle cells are mostly going to be fibroblasts and myofibroblasts, and they'll be mostly actin positive, and the spindle cells will be negative for the vascular markers, ERG or 31, or 34 is a little bit tricky because it can stain some normal dermal spindle cells. So that's helpful because at Kaposi's, a lot of the spindle cells that are kind of infiltrating the dermis are not fibroblasts, but actually are endothelial cells that are spindled. So if you don't have an HHV8 on hand, using an endothelial marker and an actin will help. Now I don't have those markers on this case because I recognize this on H&E, and a lot of times there's going to be a lot of spongiosis over top, and I find that for a lot of chronic inflammatory and reactive conditions of the lower legs, you'll often see spongiosis and eosinophils. And I think that this is because a lot of times these are very uncomfortable conditions. The patients will sometimes apply, creams or, oils or different things to try to relieve the symptoms. And then sometimes that will initiate a secondary contact dermatitis component on top of it. So I feel like a lot of times I see contact dermatitis superimposed on other things that are kind of irritating and reactive or inflammatory on the lower extremities, like the shins or the ankles. So this is a really nice example of just like the most extreme stasis dermatitis you can imagine. Just those vessels have been proliferating for a long time, but really nice. But it's good to remember that these can really mimic microscopically and clinically vascular neoplasms. So don't make that mistake.